So this brings our discussion to our first speaker, Dr. Steffie Woolhandler. Dr. Woolhandler is a distinguished professor at the City University of New York, Hunter's College, a primary care doctor in the South Bronx, and a lecturer in medicine at Harvard Medical School, where she was formerly professor of medicine. She has published more than 150 journal articles, reviews, chapters, and books on health policy, and is a leading advocate for nonprofit healthcare. She is co-founder and board member of Physicians for a National Health Program. Among her influential scholarly articles are studies on patient dumping, which led to a federal ban on the practice, medical bankruptcy, co-authored with Elizabeth Warren, waste in hospitals and in medicine, and more generally, and proposals for single-payer health reform. Thank you, Steffie.
Okay. Just a moment while we get this screen share going. Thanks. Okay, well, I have no financial conflicts of interest. I have co-authored several scientific papers with Senator Elizabeth Warren, and I served as an unpaid policy advisor for Senator Bernie Sanders, both of whom were presidential candidates and advocated Medicare for all. The United States has having quite a crisis. I know things are not great in Canada with COVID-19, but as of a few days ago, the United States was looking even worse than Canada, actually substantially worse. We've also had the phenomenon in the United States where we have extremely high death rates among Black and Latinx people, minority people, from COVID-19. This is for the city of New York, but it's believed to be true generally in the country that death rates among our poor and minority populations are nearly twice that of other Americans. Part of what made us so vulnerable was that the healthy American people had been lagging for decades. And here I've graphed the life expectancy in 5 countries. One's the US there in red, and Canada's in the middle there, I think, in blue. And until about the 1980s, the United States was the middle of the pack, and our health was improving at exactly the same rate as everybody else's. But since the 1980s, the United States has more or less fallen off the curve, and our life expectancy is now 2 to 3 years shorter than that of other people in other affluent nations. And this is not just our minority population. In fact, when we look at the death rates in the United States, compare the excess deaths relative to other G7 nations, other affluent developed nations, both white Americans and Black Americans are experiencing significantly higher death rates than people in other affluent nations. So this set the stage, if you will, for the current crisis that we're having with the pandemic. Now, what role does private insurance and the coexistence of private insurance with public plans have on the healthcare system? Well, first of all, you have unequal reimbursement that makes publicly insured patients undesirable and reduces their access to care. So this was a secret shopper study where research assistants posed as parents and tried to make an appointment for a child that had been seen the night before in the emergency room. And they called and asked if they said that the emergency room doctor said the child needed to be seen urgently within the next 2 weeks. In some scenarios, they said, oh, my 10-year-old daughter has a broken arm, can she get in to see you as an orthopedist? And others, they say, oh, my 10-year-old daughter is very depressed, can she get in to see you as a psychiatrist? But it turned out that if you have private insurance, virtually all of the time you can get an appointment with a specialist like an orthopedist. But if the child has public insurance, the parent was able to get an appointment only 20% of the time. So within specialists, significant discrimination against publicly insured patients relative to folks who can get them the higher fees that you get privately. It turns out that Medicaid patients, people with public insurance, who had PCP pneumonia, which is a type of pneumonia people get if they have a bad immune system, if you're publicly insured, you end up getting less medical care, like bronchoscopy and ICU care, and you're more likely to die in the hospital. So public insurance associated with less receipt of care and higher mortality. And this is looking at breast cancer diagnosis, the stage of the cancer at the time of the diagnosis. And it's a little bit complicated, I'll explain it to you. If you're being diagnosed with breast cancer, you want to be in that green area. You want to be one of those people whose cancer is diagnosed while it's still local or localized. You definitely don't want to be in that pink area where you've already got distant spread of the cancer. Yet publicly insured patients on the far right were much more likely to get that late diagnosis when they already had a distant cancer, whereas privately insured patients could get in there earlier and get an earlier diagnosis of the cancer. The other problem is that the unequal reimbursement for public pay versus private pay patients creates what we call rich hospitals and poor hospitals. The hospitals that see primarily public patients are poor, private patients makes them rich. So this is what a private pay hospital looks like. This is UCLA's medical center in Los Angeles. And this is about 20 miles away. King Drew Medical Center. Doesn't look too bad, but in fact was quite run down and decrepit before it was closed. And it was closed. When it was closed, King Drew was the only hospital that served South Central Los Angeles. South Central Los Angeles is a poor area with 1.5 million people. So when that hospital closed, 1.5 million people no longer had a hospital. To get to the nearest hospital, you needed to get on a bus and ride for more than an hour from King Drew to LA County Hospital. So the public payment, the low public payment, the inability to modernize that hospital to maintain quality caused it to close and caused serious access problems for 1.5 million poor people in Los Angeles. And this is seen around the country where hospitals that serve poorer patients, in this case Black and Latin patients, serving poorer and disadvantaged patients, have lower funding for their buildings to modernize their buildings and purchase new equipment. And in this case, Black serving and Latinx serving hospitals were defined as the 10% of U.S. hospitals that have the highest share of Black and Latinx patients. And those hospitals had about 50% less funding to modernize and upgrade their buildings and for new equipment. And this is national data from the federal government. And not surprisingly, those Black serving and Latinx serving hospitals were much less likely to offer high technology services relative to other hospitals that served mostly whites. They were only 71% as likely to offer MRI, about half as likely to offer PET scans or robotic surgery or cardiac catheterization or cardiac surgery or bariatric surgery. So lower funding going to hospitals that serve primarily public patients, and higher funding and going to hospitals that serve the privately insured. And this is what a public hospital looks like in Brooklyn, New York. This is Kings County Hospital. It's actually a decent hospital, but there's certainly very little in the way of amenities in this waiting room, as you can see. But it's not just urban populations who suffer in this way. In a lot of rural areas, people are very low income. They're mostly publicly insured, and that has caused many rural hospitals to close. Over 90 rural hospitals have closed since 2010, and about a third of them were more than 20 miles away from another hospital. So it's a pretty serious problem in terms of the hospital being poor, in terms of it closing down and cutting access for publicly insured patients. Now, what's going on here is we have created in the United States a market-driven healthcare system. And this is a book by my former colleague, Regina Hertzlinger. It was quite a famous book where she said, oh, what hospitals need to do is think of themselves as businesses, that it's a market, and you're going to turn your hospital into a focused factory that selects a product line like hip replacement or hernia surgery. You're going to focus on one product line and do that really well and make a lot of money. You're going to be a focused factory. And unfortunately, American hospitals have taken that to heart, and there's tremendous overpayment and excessive profits from doing things like elective surgeries relative to the routine services. And that payment inequality warps hospital and physician priorities. This is actually a quote from the CEO of the largest for-profit hospital system in the United States. It's called Stewart. And they got in big trouble during the COVID epidemic because they couldn't do elective surgery. Now, there were plenty of sick patients everywhere, plenty of patients needing ICU care, but they were in financial trouble because they had developed their product line of elective surgeries. And he said, elective surgeries are the cornerstone of our hospital system's operating model, and the negative impact due to cancellation of these procedures cannot be overstated. So they had specialized in surgery and couldn't really make it taking care of sick people with COVID. And this is an example of the focus factory. This is actually the David Koch Pavilion at Hospital for Special Surgery in New York City. All they do at this hospital is orthopedic procedures. They do not see Medicaid patients at all, one type of public insurance. And many of the doctors there refuse to take care of patients with Medicare, the other type of public insurance in the United States. Just to state the obvious, the place is a palace. It's on the East River in Manhattan, New York, and I can't even imagine how much that piece of real estate is worth. But inside, every room has a view of the river. It's absolutely gorgeous. But is this really our priority, to be providing elective orthopedic procedures in this kind of palatial setting and excluding public patients? This is actually speaks to the behavior of orthopedists. And it turns out orthopedists who own a hospital or surgery center are much more likely to operate. So in this case, orthopedists were presented with scenarios about patients with conditions like carpal tunnel, it's a wrist problem, rotator cuff, it's a shoulder problem, or a knee arthroscopy, obviously a knee problem. And if they owned the hospital or the surgery center, they were much more likely, in some cases almost twice as likely, to say you required surgery and that medical and physical therapy measures were not going to be enough. Finally, if you allow insurance firms into your system, they will gain financial and political power. They will thwart change and can become, in the case of the United States, almost too big to fail or too big to regulate. So this was a meeting that occurred literally days after Donald Trump was inaugurated. Some of the first people he invited into his Oval Office were health insurance executives to signal that they had power, that he was going to listen to them. But it's not just Donald Trump. Our congressmen, our state legislators receive huge amounts of campaign financing, huge amounts of lobbying from the health insurance industry, and they've become a major impediment to change, and they've actually resisted effective regulation. And now I'm going to turn this over to my colleague, Dr. Himmelstein.